Hello, once again to all of our listeners and viewers. I'm Malcolm Bell. I'm here with another in our series of interviews with the experts. Today's topic is hybrid procedures, collaboration with interventional cardiology. And I'll just really make sure it's very clear. We're really talking about congenital heart disease interventions and surgery. I'm joined today by two of my colleagues and guests here. We're very fortunate to have them with us today. The first is Dr. Jason Anderson, who is an associate professor of pediatrics. He's a pediatric and congenital interventional cardiologist. He's also the medical director of the Todd and Karen Wernick program for HLHS. And with him today is Dr. Elizabeth Stephens, who is an associate professor of surgery and is a congenital cardiac surgeon. So welcome both of you, Jason and Elizabeth. This is a really, I think it's going to be an exciting episode we have here. It's something we don't discuss very often at all. So I'm going to just start with the obvious question here, and I'm not sure all of our listeners will be familiar with what hybrid procedures actually entail in this population. Certainly I, as a adult cardiologist looking after adult patients, when we think about hybrid operations, we may be thinking about whether it's valvular interventions or coronary disease. But this is completely different. We're talking about congenital heart disease. This could be in babies. It could be in adults. And so, Elizabeth, maybe I could just have you, describe, what is hybrid procedures in cardiac surgery?
Well, first, thank you so much for having us. I think generally speaking, we would consider those procedures to involve both a catheter or wire-based technique along with a surgical technique. And so the hybrid being those two techniques coming together in some form. Sometimes that means in the same setting, in the same OR, literally physically in the same incision, working together side by side. And sometimes those are staged. So doing a surgical procedure immediately followed by a catheter-based procedure. But I think those lines between, what's surgical and what's catheter, less invasive, is really blurring as we continue to work together.
Jason, I did hear how you would define this, and particularly, we've heard about using wires and catheters here, and obviously this is one of your skill sets.
Yeah, and thank you again so much for having us, Malcolm, and for everybody that's joining. And I completely agree with what Elizabeth outlined. This is the overset or the cross pollination of our professions, and it's where our expertise overlaps. And interesting, Malcolm, you said this is something we may not see in our standard adult conditions in cardiology, but actually it's something that is an opportunity if you have a difficulty for access, if you have a difficult angulation or something where you might need a sternotomy and then a sheath actually directly into the atrial source or ventricle. And so really what it allows for is the utilization of both skill sets in an overlapping and simultaneous manner to ensure we can offer the optimal forms of treatment and any form of treatment that a patient may need or necessitate due to complexity. And of course, that seems to be more prevalent in our congenital heart disease populations.
Yes, and I'm sure many of our listeners who have looked after patients with adult congenital heart disease and certainly in pediatric population, you made the point about it may be difficult to access and things. And I can't think of a population of patients that really would describe, fit into this more than the patient with congenital heart disease. With very complex anatomy and very often after earlier procedures, and we may get back to that later. So, and Elizabeth, you made the point. It can be done synchronously. It's done at the same time in the same operating room at the same time. It could be done, sequentially, but I assume that sometimes this could be done even days or even weeks apart. Preparing someone for surgery or preparing someone for an intervention that's percutaneous. Would that be fair?
Yeah, absolutely. So for each case, when we're trying to think about how to optimize care for a patient, we're thinking through what types of wire-based or catheter techniques, how do we set up for success in that realm? And how do we have a complementary surgical or incisional approach that gets access to where we need to be? And like you said, that may be literally in the same OR with a fluoroscopy type setup, and it may be staged such that either surgery sets up for a planned catheter intervention or vice versa.
Jason, in terms of the diagnoses, I mean, the conditions that we're treating here, what would be sort of maybe the top 2 or 3 in terms of frequency? And at what age are we doing this? I mean, we're talking about babies, we're talking about young kids, adults, or are we talking about the entire spectrum?
Yeah, it really is a ability or an opportunity that can offer therapy to the entire spectrum of age populations. And I'll give a couple examples because that will oftentimes help kind of guide the reader or the listener to what we're thinking. And a simple example is a VSD. And so when you're looking at a ventricular septal defect, you may have a large hole in the bottom of the heart. It may be in an area that's very difficult to visualize surgically. And so as Dr. Stevens opens it, that muscle is intertwined. And when you look down, it can be very hard to tell where the true orifice or origin of the defect is. And it can be even more difficult to close it when you're under circulatory arrest. And so that may be an opportunity where we would access the heart, and with the heart beating in real time, we can go in with smaller catheters guided by Dr. Stevens while we put a device in under echocardiographic guidance, giving us a real-time assessment of not only device fit, device closure, with the expertise and ability to intervene and achieve a better outcome if necessary from a surgical standpoint. And now while that may be a population more consistent with a baby, conversely, we could think about a 50-year-old patient who's had a form of palliation like a mustard, where we've made baffles inside the heart, and we need to open those baffles. But those patients may have had 4, 5, or even 6 prior sternotomies, and getting all the way in to do the procedure surgically may be hard. So if we can make a window, get access to the heart, and then get an angle appropriate for us, we can do things in more of a minimally invasive manner, but also allowing us the benefit of getting the angles we need to be successful and optimize our outcomes with a first try.
So these are, very complex, patients, and we talked about babies. I mean, sometimes you're even aware of what you're going to be dealing with before the baby is even born, and then you may be dealing with someone who's 50 years of age, who's been dealing with adult congenital heart disease all of their lives, and may have had a number of procedures. So we know that these are complex patients, and it probably takes more than I'm not going to say just, but maybe takes more than a cardiac surgeon and an interventional cardiologist to work out, what they do. They obviously are, well aware of what they can and cannot do. But what goes into making this decision? I mean, presume I think earlier, one of you said, this team approach, and that it's, but presumably this would be with your colleagues, your pediatricians or adult congenital heart disease specialists, imagers, and maybe other groups. So maybe you could just paint a picture for us, how do you approach this sort of in that multidisciplinary, with that multidisciplinary team?
Yeah, no, you're absolutely right. There's a large group that are involved in the planning for and the discussions about what approaches, and imaging is certainly really key because we're trying to figure out, access and routes and stents or baffles or things like that. And so our ability to get 3D imaging and looking through that in preoperative planning, pre-procedural planning is super important. Understand that physiology, so from a cardiology standpoint, and sometimes we're undergoing a cath to understand that physiology better, measure pressures and resistances, and help decide as well prior to the decision making. I think it's really important that we have a group that is used to working together and are open to ideas and able to be very forthright about thinking outside the box and try to bring forth what the best outcome is for the patient, whether that is catheter or surgical or combined. So I think that's been wonderful here that we have strong relationships. We're used to working together. And that's really kind of a foundation that's the basis for these discussions, just having that trust and experience with one another.
Jason, I mean, this is obviously really important, but I think our listeners would sort of like to sort of try to picture how that's done. So how do you operationalize that? Is this a weekly conference, or is this something that's sort of nimble, done on the fly because, you know, you're meeting all these people in the cath lab or outside the operating room or in the radiology area? How is it actually done? And maybe I'll throw in one other question there. Do you involve the patient or the parents in that discussion at that time before, or you just give them, you know, what your recommendations are? So, because obviously in terms of shared decision making, they're probably the most important person in this. But.
Absolutely, and the answer is all of the above. And so we not only review all cases as a collaborative group, making sure that all the expertise and wisdom within the room is sought out, because we have cardiologists of many different stages in their career who've undergone opportunities to learn and see outcomes through many different phases. You must remember, a generation ago, we were talking about survival. We were talking about how do we get through tomorrow. That is no longer the discussion. The discussion now is what can we do today so the patient at 50, 60, 70, 80, and 90 years old, you cannot tell they have congenital heart disease. That is our goal. So exercise, physical activity, incorporation into daily life and all the activities the patient wants. And so that discussion is a team-based approach. It's the family, the cardiologists, the interventionalists, and the surgeons. And it's through weekly conferences, and every day we're in communication with each other. Elizabeth and I talk all the time, and I'll be in the room operating. And if I see an opportunity where we can improve a patient's outcome from something we didn't perceive or plan on, Elizabeth's the first phone call. And we meet in the room in the cath lab and we say, how can we make things better? How can we improve outcomes for this patient? And so we do not want to miss any opportunities.
And obviously, I mean, at Mayo, you know, we've got a rich history of, you know, pediatric and congenital heart disease surgery and the long legacy there. And I'm sure you're the beneficiaries of that, as our patients. We've learned a lot. But I think what you're also saying here is that you want to do a procedure today that maybe avoid something else in the future or optimize the chances that they'll be eligible for maybe a less invasive or a less complex procedure. And is that really what you're saying?
Yeah, and I think also trying to decrease the total number of interventions, right? So, for instance, tetralogy of Fallot is an example that has changed over the last 10. Well, I mean, we could go back even further, but now as a baby, when we have a fetal diagnosis, I meet with the parents, but they're often meeting with an interventionalist. So if the baby is too blue at birth, then that traditionally would have been a BT shunt. Well, many of our babies are getting a PDA stent. So that allows them to get to their first complete repair without a sternotomy, without a bypass run as a neonate. And then when you flip forward to the time when they're needing a pulmonary valve replacement, we're meeting as a group and actually looking over these, you know, really one by one. We're trying, they're now more catheter-based interventions, but in some cases we'll say, gosh, they're a good surgical candidate now. We can put in a nice size bioprosthetic, you know, ring that sets Jason up for, you know, basically a lifetime of catheter-based interventions. That might be a best approach. Another kiddo, we might say, gosh, maybe a catheter intervention will give them some more time before another sternotomy where there is an eventual sternotomy. And in that kiddo's time, they can grow to be, you know, more adult size. And that might be the next. So again, looking forward to how we can each set up the other for success and overall optimize the care of the patient, and including our families and patients in those decisions. Why are we talking about these different approaches? What are the risks and benefits? And what we think is, in our opinion, probably would be the optimal, but often, you know, that's a decision that they're very involved in.
Yeah, so there's really no sort of fixed order on whether the catheter procedure is done first or surgery. It's going to depend on the condition you're treating, the age of the patient, and really what you're trying to do then I think what you're emphasizing here is you really want to set them up for the best outcomes possible. And we talked about the frequency of other procedures or surgeries in the future. So let me then ask another question here. And this is something that I really not that familiar with, and it's the use of these pulmonary flow regulators. And I'm just wondering if, it sounds like a relatively new advancement. I don't know who to ask here, Jason or Elizabeth. Either you can jump forward here. Can you explain what these are and how they're used?
Maybe I'll get started and then pass it over to Elizabeth, because that's actually the standard progression when we use them. Is you'll start with me and then transition to Elizabeth.
Well, that's another question I had. So
Pulmonary flow regulators are a wonderful example of what can be done when there's collaboration between your surgeons and your interventionalists. And what they represent is an ability to regulate flow. So many of our lesions allow for mixing, so the blood can kind of pool inside the heart and choose whether to go to the lungs or the body. And in those lesions, if there's too much going to one or the other, it can be detrimental to the patient. Now, most of the time we're talking about too much blood flow going to the lungs, stealing it from the body. And oftentimes the kind of famous lesion for this is hypoplastic left heart syndrome, or where you think of somebody that's having only part of their heart or part of the structures that are needed. And in order to kind of balance that flow, we can regulate the flow that goes into the lungs. Dr. Stevens does this with bands. You can actually put bands on the outside of the arteries to the lung, which help narrow it. And pulmonary flow regulators are actually a device that go on the inside that we then fenestrate or make a hole in. So we, in essence, are reducing the luminal side to add resistance. No different than plumbing, like plumbing in a house. It's all the same hemodynamics. And when we reduce that orifice or the hole, we raise the pressure needed to cross it. And so we can even out the flow. Now you might say, why do we want to do that? Well, if a patient's born premature, maybe very young or very small, maybe a 1.5 kilogram child, the size of your palm or smaller, that would be a very difficult thing to do surgically. It may raise the risk and make the surgery far more difficult, because we might choose to put those devices in, which we do via a catheter. And once they're in, we can help balance that flow to allow for growth and time. But that's only part of the story, because while allowing for time, we often then will end up with a more definitive palliation. And we have to remember, when we're putting something in, we need to have a strategy about how to get it out. And that's often where they'll end with Dr. Stevens after those have been in for a set amount of time.
Yeah, so we're able to, at the time of complete repair, basically peel those off the inside of the PAs, and we've learned, how long they can stay in safely, and we thankfully have been able to have really good success with those. That, as Jason says, will decrease the pulmonary blood flow, which in some babies in particular has cause heart failure or failure to grow, and then that allows them to get to a definitive surgical repair. So they've been really helpful, and we use them in a number of situations for a variety of diagnoses.
So I'm just going to finish with a question here that maybe is more philosophical. So we often talk about percutaneous interventions. We talk about surgery, and we compare, and then there's the hybrid approach, and then we think about what percentage of patients are eligible for each. It sounds to me that you don't look at it that way. This is sort of a longitudinal, at least for the complex disease. I mean, I'm sure there are probably some conditions that still are just catheter-based treatment. I mean, there's not a need for surgery, and there's probably some surgical procedures that you don't necessarily need the help of someone like Jason. I mean, correct me if I'm wrong, but I I'm also hearing that, some of the surgery you're doing is maybe made just a little bit easier with a better outcome just because of some of the upfront work with catheters. So is it fair to say that hybrid procedures in this patient population, whether they're babies or teenagers or older adults, that the hybrid approach really should be the standard approach? I mean, in terms of the mindset, as I said, I'm sure there are procedures that don't lend themselves easily to hybrid, or not, it's unnecessary. But is that fair? Is that what you see yourself you're practicing, that this is a team approach with all the other people that you've talked about, but as long as you're just thinking about what's coming next and hoping to delay that for as long as possible? And Elizabeth, maybe you could follow up on that.
Yeah, I think that's actually a really accurate way to describe for many of our patients that over the course of their lifetime, they're going to be expected to have a series of interventions of various, we use the word invasive, but does that mean full sternotomy? Does that mean surgical intervention? But a combination of what we would consider surgical interventions and catheter interventions, some of which also could be, in a single setting. And the optimal strategy is having all your minds together, all the people who are involved in those types of procedures and their, primary caregivers, their family, involved in sorting out, to the best of our knowledge, how can we make those combination of procedures as ideal as possible in terms of quality of life, length of life, and also quality of life in between those procedures.
It would be fair to say that at least some of the very complex surgical procedures that may have been done in the past have now become somewhat safer or perhaps easier to do with this approach? Yes. Yep. Okay. So, Jason, I may just then give you the last word here. And I don't know if you want to add anything to what Elizabeth said in response to my statement. But maybe just one quick question is, we talked about these hybrid procedures. How often are these hybrid procedures done concurrently in the same room, down in the operating room?
Yeah, when the hybrid procedure is needed, we're doing them in the same room, in the same location. And whether that's the OR or the cath lab, it's whatever's going to give the patient the best outcome. And based on the kind of highest need, whether it's device selection, device utilization, or access or imaging. And those are some of the things that we decide as a team before starting the procedure. But I think you described it beautifully. Our goal is lifetime management for our patients. Our goal in Mayo Clinic is the needs of the patient come first. And we're so fortunate to be surrounded by such talent. And the hybrid procedure is just a representation of collaboration. It's the bringing the skill sets available at hand together to optimize the care of our patients.
Well, thank you so much. This has been incredibly informative. I want to thank you both for taking the time to share your experience and expertise and perspectives on this and this very complicated or complex your population of patients. And again, just emphasizing this could be starting sort of prenatal, but certainly the baby. The birth of the baby or very shortly afterwards, but it's a lifetime, and it's obviously there are thousands and thousands of people who depend on this, and it's not just the patient, of course, it's the parents. Starting very early. So thank you so much, and I want to thank all of our listeners and viewers again for joining us today. Look forward to seeing you at a future podcast.